Well, thank you very much for that very generous introduction. Yeah, I'm David Lewis and I've come from Plymouth in the UK. Just to talk to you about bispecific antibodies largely and where they sit in the current treatment for diffuse large B-cell lymphoma. Really there's three parts to this talk. The first talk is really highlighting the unmet need of where we are with patients with diffuse large B-cell lymphoma, and I'll try not to spend too long on that because I'm sure you've heard that in other sessions. The second part of the talk, I'm really going to talk in detail about the current evidence for the currently available CD3, CD20 bispecific antibodies in diffuse large B-cell lymphoma. And the final part of the talk, I'm just going to take you through some cases of patients that I've treated in Plymouth. And hopefully we'll have some time for discussion at the end. Here's some disclaimers, and here are my disclosures. So, as I'm sure everyone's fully aware, I mean, actually, with diffuse large B-cell lymphoma, for the majority of my career, the novel therapy that was available was rituximab. But really, over the last 5-6 years, we've had a proliferation of novel agents that have become available in immune-activating agents such as tafasitamab, CAR T-cell therapy, of course, which has really changed the management, particularly of relapsed refractory diffuse large B-cell lymphoma, and a number of indications for CAR T have appeared on in the last few years. Antibody drug conjugates have obviously become important in the treatment of diffuse large B-cell lymphoma, particularly in polatuzumab and more recently Lonca-T. And then most recently, the license approvals for these agents, bispecific antibodies. Now, I think we're very much at the beginning of the story when it comes to bispecific antibodies, but we've now got two license and one reimbursed, the other one about to be reimbursed, CD3, CD20 antibodies for diffuse large B-cell lymphoma in the third-line setting. And this is what happens to patients with diffuse large B-cell lymphoma, and this is really just to highlight the unmet need. So although the vast majority of patients receive first-line treatment, and we do cure the majority of patients who have first-line treatment with R-CHOP type treatment, but of course there are some patients who can't receive R-CHOP for whatever reason. About a third of our patients go on to receive second-line therapy, and the prognosis and outlook for these patients does remain poor, and these patients have, despite the advancements in treatment, remain a challenging group of patients to treat. And in fact, you can see that a large proportion of those go on to receive third-line treatment after second-line treatment. Historically, outcomes in the chemotherapy era have been very poor with patients with second-line treatment. The Scholar database is a database that made up largely of clinical trial data combined with real-world evidence. And you can see that in the real-world setting, the vast majority of patients who have relapsed refractory diffuse large B-cell lymphoma actually do very poorly, with very poor progression-free survival and overall survival, particularly in those patients who progress quickly after their initial treatment, those patients who progress within 12 months of initial treatment. Now, CAR T cells have completely changed the landscape in relapsed refractory diffuse large B-cell lymphoma for a subset of patients, but they remain challenging to deliver. They're associated with significant toxicity, and they don't cure everyone, as we'll go on to see. So very briefly talking about CAR T, there are 3 randomized studies that have reported evidence that they improve outcomes in the second-line setting compared to standard immunochemotherapy and autologous transplant. The Transform study, using liso-cel in the second line, you can see showing very high overall response and CR rates and an improvement in progression-free survival compared to standard of care. And of course, the Zuma-7 study looking at second-line axi-cel therapy with a significant improvement in PFS and subsequently a reported overall survival benefit, which was reported more recently. So because of these randomized studies showing a benefit over chemoimmunotherapy, CAR T cells are now a recognized option for second-line treatment of diffuse large B-cell, particularly for those patients who relapse within 12 months of initial treatment, because those are the patients that are going to do particularly badly with standard chemotherapy approaches. However, CAR T-cell is not without its challenges. First of all, I mean, our UK experience is we've got a limited number of treatment centres. The CAR T is not a treatment you can give in every hospital. And the geography and the logistics of CAR-T remain a challenge for a lot of patients. Secondly, there's the fact that the actual CAR-T cell product itself takes 3 to 4 weeks to be manufactured. And so during that time, the patient may well progress. And certainly in the UK, we have a large number of patients who, despite being referred for CAR-T cell therapy, never make it as far as the CAR-T cell infusion because they progress or become too unwell to actually receive the product in the time that it's being made. The second problem with CAR-T, of course, is that even if patients get to infusion, there's a significant relapse rate. So despite CAR-T cell therapy curing a significant number of patients that would otherwise not be cured, there are still patients who will relapse following CAR-T cell therapy. And so there's an unmet clinical need for these patients who will go on to need third-line treatment after CAR-T cells. And of course, CAR-T cell treatment is associated with significant toxicity, with very high rates of cytokine release syndrome and ICANS. And I think we'd all be slightly concerned about taking patients with significant comorbidities to CAR-T cell therapy. So we've improved a lot, and we've got new options, but we can still improve, and we've still got treatment. We still need to offer treatments to these patients who relapse after CAR-T cell. So I think into this space is where our bispecific antibodies are going to sit. So currently we've got 2 licensed agents, CD3, CD20 bispecific antibodies, which have recently been licensed for the third-line treatment of diffuse large B-cell lymphoma, i.e. patients who've had 2 prior lines of treatment. And I'm going to spend a little bit longer going through the studies, the pivotal studies that have led to these licenses. First of all, let's talk about the Roche product, glofitamab. And I will talk about this in more detail later on, but you can see that, remember the scholar data I presented to you before. Those patients, this is a very, very poor prognosis group of patients. And you can see that these patients who get a complete response to glofitamab have about 2-year progression-free survival of 63%, which compared to historical controls is really quite impressive. And similarly, a very good overall survival considering this is such a highly refractory, poor prognosis group of patients. The overall response rate in the GLOFIT study was about 50% with a CR rate of 40%. Oh, sorry, I thought I was using the mic. Apologies. Can you hear me okay? Yeah. Talking now briefly about the epcoritamab data, you can see similarly, patients who get a complete response have a 24-month progression-free survival of 75%, with again a highly impressive overall survival, almost 90% of patients still alive at 2 years of those patients who get a complete response. With, in the epcoritamab study, the primary endpoint was overall response rate, and similarly, about 40% of patients got a complete response in the GEN-01 study, which I'm going to talk about in more detail in a minute. Would you like me to mic up?
Sorry, doctor. Would you mind using this one?
No, apologies. Can you not hear me very well?
Yeah, they cannot. Sorry.
Is that better? I'll just hold it. Can you hear me now okay? No, not at all. It's got worse.
Doesn't get worse. Yeah. Sorry.
There we go. That better? It's all right. I'll use this. This will be all right. I'll just try and talk close to the microphone. So again, highly impressive progression-free survival and overall survival, particularly in those patients who got a complete response. So 40% of patients get a complete response, and you can see highly impressive PFS and OS. I'm just going to drill down now into the clinical trial data to talk through that in a bit more detail. So first of all, coming to the epcoritamab clinical data. So epcoritamab is currently the only available subcutaneous CD3, CD20 bispecific antibody. And remember, I mean, I'm sure people in the room are familiar with bispecific antibodies, But a bispecific antibody is an antibody that is capable of engaging two targets at the same time. All of the currently available lymphoma-directed bispecific antibodies engage CD3 on T cells and CD20 on the target lymphoma cells. Interestingly, it binds to a different epitope on CD20 than rituximab does, which does potentially lend itself the option of combination chemotherapy in the future. And it brings the T cells close to the target, and thereby they kill the cancer cell via cell-mediated toxicity. There may also be some direct toxicity from the bispecific antibody itself, but these antibodies do not engage macrophages in the same way that rituximab does. So the vast majority of their activity comes from redirecting T cells, patient's own T cells, against the cancer cells by engaging CD3 and CD20 simultaneously. Epcoritamab has a unique DuoBody technology developed by Genmab, whereby you get a bispecific IgG1 antibody, which are very stable in vitro and in vivo and behave very similarly to regular IgG1 antibodies. And this allows, one of the reasons it allows subcutaneous dosing is because it's such a stable molecule. Really, I said to you a few minutes ago, and hopefully you could hear me, I think we're at the very beginning, actually, of the development of these agents. What I'm going to talk to you about in the coming slides is the current indication, which is epcoritamab monotherapy for third-line treatment and beyond of diffuse large B-cell lymphoma. But actually, there's a huge number of ongoing clinical trials in different disease areas and looking at combination therapy as well. A large number of these our centre has taken part in, actually. We've actually given about 30 patients epcoritamab across a number of different clinical trials, but you can see that epcoritamab has been investigated in different diseases, including follicular lymphoma, mantle cell lymphoma, and in early lines of treatment than third line. So this is for the future. What about where we are now? So we took part in this study in Plymouth. This was the NHL-1 study, the pivotal phase 1, phase 2 study, which established, first of all, the dose for epcoritamab, and secondly, examined its efficacy across a wide number of different lymphoma indications. I'm focusing today on the diffuse large B-cell lymphoma cohort, which is what's led to its license. I've written the key inclusion criteria on the graph there. You can see that this is patients who had relapsed refractory diffuse large B-cell lymphoma. I just want to highlight to you that this study did actually allow patients in who had an ECOG performance status of up to 2, in contrast to a lot of other studies which have a cutoff at 1. Patients needed to have at least 2 prior lines of anti-cancer therapy. Importantly, and I'll come on to it in more detail later on, prior CAR T-cell therapy was allowed in this study. And I've also put the dosing schedule up there for epcoritamab. So epcoritamab is given in 4 weekly cycles. For the first 3 cycles, epcoritamab was given weekly. Subsequently, it is given every 2 weeks up to cycle 10, and then it's given once every 4 weeks. And the trial protocol was to either progression or toxicity. But I would add another reason to stop the epcoritamab there, which is patient choice. And I actually did have a number of patients that did stop epcoritamab because of choice as opposed to any other reason. The first cycle of epcoritamab is given as step-up dosing to mitigate the risk of cytokine release syndrome, with the first full dose being given on cycle 1, day 15. And the full dose is 48 milligrams. The primary endpoint of the epcoritamab study was overall response rate, but we did collect other endpoints such as duration of response, CR rate, and overall survival. And I'll talk you through that in more detail over the next few slides. Now, this is a really key slide, actually. I mean, I think when you're looking at a paper or data, it's really tempting to skip, isn't it, to the progression-free survival and OS curve. But I would always look closely at the patient characteristics in any study, because it can be quite cynical, I think, sometimes, that often studies have very selected group of patients. That is not the case in this study, and I want to highlight to you a few things. These were a very, very highly pre-treated, difficult group of patients. You can see, first of all, that the number of prior lines of therapy, the median number was actually 3. And bear in mind that most patients who with diffuse large B-cell lymphoma after their first line of treatment are in trouble. Median number of lines was 3, and up to 11 prior lines of therapy. 40% of these patients had had prior CAR T-cell therapy. of which the majority were refractory. And you can see that 75% of these patients were refractory to at least 2 prior lines of therapy. There was also significant numbers of patients who had double-hit lymphoma and transformed low-grade lymphoma. And you can see that although there were relatively small numbers of patients with ECOG2, there were some patients with relatively poor performance status in this study. So this was not a select group of patients who were, this isn't a study where they selected off, if you like, good players. This was a genuinely highly refractory, difficult group of patients. And certainly the patients we put into the study were all very challenging patients. And even despite that, despite this very difficult group of patients, overall about 60% of them responded. So electing partial response and CR rate, with a CR rate of almost 40% in this very challenging group of patients. So, and I think, as we'll come on to in the next slides, but the achievement in a CR really is achievement of a CR really is an important endpoint for these patients. The patients who do really well with these drugs are those who get a CR. Here's the waterfall plot just showing you the reduction in size of the target nodes in each patient, showing that the majority of patients, even so, to actually get counted as a response, you needed to get to that line, because that's a 50% reduction, which would get you to the response. But you can see that even the patients who didn't, strictly speaking, get a response, a lot of patients did have some effect of the antibody. And again, response rates across subgroups, again, really important. I think a lot of people are going to be using these antibodies in patients who had prior CAR T-cell. And the epcoritamab study had the largest number of patients with prior CAR T of any of the bispecific studies thus far presented. And you can see that of those patients who had prior CAR T, response rates were comparable to those who hadn't had prior CAR T, with about 30% getting a CR, even having had prior CAR T-cell therapy. So there was no subgroup of patients that performed particularly badly in this study. This is just showing you what happened to these patients over time, and this is really just to emphasize that responses with epcoritamab tend to happen quickly. The majority of patients, so our practice outside of clinical trial is to do a PET scan at about 3 months of treatment, roughly. That's when I tend to look. And actually most patients will have a CR at that point. You see CRs early in these drugs. There are some patients, though, who get a partial response who do subsequently achieve a CR in a later study, and those patients do equally well. So don't panic if your patient, obviously you want your patient to get a CR on the first scan, but don't panic if they get a good partial response and they still have some activity. They may well convert to a CR on a later scan, and I would continue the drug in those patients. But you can see the median time to response is quick at 1.4 months. Personally, I don't look that early. In clinical practice, I would look at about 3 months. But in most patients, clinically, it's usually quite clear if they're responding because they get better. And again, those patients who do get a response have an impressive duration of response. You can see that the majority of patients, actually, who have a response, this is including partial responders, do remain in remission. But you can see particularly those patients who get a complete response, where the vast majority of those patients who get a CR are remaining in CR. And again, this graph really highlights the importance of achieving a CR. You can see the patients who get a CR, this is overall survival we're looking at now, actually have a fantastic overall survival, with the vast majority of patients remaining alive. And I would say well, in my experience, alive and well on epcoritamab. You can see that patients who get a partial response, unsurprisingly, do better than those patients with progressive disease or stable disease. But the majority of patients whose best response is a partial response will at some point relapse and go on to need further treatment with something different. This is an experimental outcome of the NHL1 study. They collected MRD by cell-free DNA, which is a very interesting technology for the future, showing that actually MRD negativity was highly prognostic of outcome, with those patients who achieved MRD negativity having a clearly much better outcome than those patients who did not achieve MRD negativity. So I think in the future, MRD may be a useful tool to help us do response assessments in these patients, and may either augment or potentially replace things like PET scans in some patients. The extended follow-up data of the epcoritamab study was presented at EHA this year, showing that those patients who do achieve a CR, again, the vast majority of those, even at 2 years, are still in an ongoing complete response. And that's certainly my experience with our clinical patients. Those patients who get a CR do tend to stay well and in a complete remission. In terms of treatment exposure and discontinuations, most patients, this is with a median follow-up of 10 months, you can see that the patients who have discontinued treatment, unsurprisingly, the most common reason for discontinuing treatment is progressive disease. But I just wanted to highlight to you on this slide that from a reassurance point of view, that actually discontinuing epcoritamab because of adverse events is actually quite rare. I can't think of a patient I've discontinued it with adverse events off the top of my head, but in the study, about 7% of patients were discontinued because of adverse events. But it's a relatively low number of patients when you think about the cohort that we're talking about. This is a heavily pre-treated group of patients who've had a lot of chemotherapy and are unwell, and this is a continuous therapy as well. So usually with continuous therapies, you do get relatively high rates of discontinuation due to adverse events. So 7% I would say is a relatively small number. And in terms of adverse events of special interest, I'm sure everyone in this room now is familiar with cytokine release syndrome, largely I think because of people's experience with CAR T-cell therapy. And I think, just to put this into context, the centre I work at in Plymouth, whilst we're a big lymphoma centre and a big trial centre, we're actually not a CAR T centre at the moment. So when we started using epcoritamab in trial, we were actually quite nervous about cytokine release syndrome. But it became very quickly apparent that actually it was something that we could handle quite easily in our centre. So for cytokine release syndrome, you do see it in bispecific antibodies. You do see cytokine release syndrome. But the cytokine release syndrome I think we all are worried about is like grade 3 and above cytokine release syndrome, which is where patients are having to go to intensive care for inotropic or respiratory support. With epcoritamab, you can see that whilst about 50% of patients do get a degree of cytokine release syndrome, it's highly predictable in terms of timing, with the vast majority of patients who get cytokine release syndrome getting it on that cycle 1, day 15 first full dose. And the second thing to say about it is, of those patients who do get it, the vast majority have grade 1 or grade 2 CRS. So grade 1 CRS, as I'm sure you've heard in other talks, is really just a fever. These are basically well patients with a fever. Grade 2 CRS is where patients are dropping their blood pressure or needing a little bit of low flow oxygen, but you can look after them very, very easily on either a day case unit or on a ward. Only 2.7% of patients who had epcoritamab had grade 3 CRS, which is basically a short spell on an ITU, usually for a little bit of inotropic support. As I said, I've treated 30-odd patients with epcoritamab across different indications in clinical trials, and I've not sent a patient to ITU yet for either ICANS or CRS. It resolves quickly in the vast majority of patients, and it only led to treatment discontinuation in 1 patient. So CRS is something you need to be aware of, and it's something that you do need to be able to treat with tocilizumab if necessary, but I would say it's something that shouldn't stop you giving it, and I can say with confidence that you can deliver these drugs in a non-CAR T-cell centre, because we have. With the extended follow-up, we've also looked at some cytokine release syndrome mitigation strategies, including a different dose ramp-up schedule, which reduce the risk of CRS even further. One thing I would say to you is that the use of dexamethasone in the initial prophylaxis as opposed to prednisolone does seem to lead to a lower rate of cytokine release syndrome. So we've routinely actually, across our entire bispecific program, including epcoritamab, switched to routinely using dexamethasone instead of prednisolone for cytokine release syndrome prophylaxis, and that markedly reduces the CRS rate. So conclusions from the GEN-01 epcoritamab study. This is the first-in-class subcutaneously administered CD3, CD20 T-cell engaging bispecific antibody. It's a really, really difficult patient subset in this study, and despite it being such a challenging group of patients, including 40% with prior CAR T, we had a CR rate of 40%, and that CR rate is maintained over time. And if patients get a CR, they're likely to remain in a CR for over 2 years. Adverse events, we do see adverse events, including cytokine release syndrome in about 50% of patients, but it's highly predictable in terms of timing, and it is usually easy to deal with in a ward-based setting. And after that first cycle of epcoritamab, you very rarely see cytokine release syndrome. Very few patients in this study actually discontinued epcoritamab because of adverse events. So I'll talk you through the glofitamab data as well now. So this is the other bispecific antibody which is coming through. This is data that was presented by Martin Hutchings last year. Glofitamab is another off-the-shelf intravenous bispecific CD3/CD20 antibody. I think the main differences in terms of administration with epcoritamab are firstly, glofitamab is given intravenously, and secondly, it has a limited duration of therapy as opposed to ongoing treatment. We've previously seen with the primary endpoint of the Roche glofitamab study was CR rate as opposed to overall response rate, and they had a CR rate of about 40% in their study. This is their dose ramp-up schedule, which I'll just skip over very briefly, but patients get obinutuzumab on cycle 1, day 1, with then a ramp-up of glofitamab over the following 3 weeks. It's given on 3 weekly cycles up to a maximum of 12 cycles. The indication for glofitamab is almost identical to that for epcoritamab, so diffuse large B-cell lymphoma after 2 or more prior lines of therapy. This study only included patients with ECOG performance status of 0 to 1. They also had some prior CAR T-cell treated patients in their study. About 30% of the patients in the glofitamab study had prior CAR T. And this was data that was presented at ASH and Lugano, showing that, again, if you get a CR rate, those CRs do appear durable in the glofitamab study. This is a landmark analysis. Bear in mind that this is not a comparable PFS curve to the ones we've seen before, because this is what's called a landmark analysis, which means you only include those patients who reached the end of the study. So by definition, in order to get to this point, the patients would have had to survive for 8.3 months. So this is obviously a selected group of patients, but you can see that those patients who do have a CR at that time point actually do maintain it in the majority of cases. And again, with a selected group of patients, impressive overall survival. And again, they see CRS in about 2/3 of patients. Again, mostly grade 1 and 2, but they did see some grade 3 events, but again, relatively rarely. Okay, so I've managed to skip through that fairly quickly. So I've got some time at the end for case presentations, and then we'll hopefully have some time for the discussion at the end.
You have 5 minutes.
I've got 5 minutes. Okay, that's fine. So this is where I work in Derriford in Devon, concrete monolith. We've got a large active clinical trials centre in Derriford, and epcoritamab was actually one of our more successfully recruiting studies. So the first patient I'm going to talk you through is a 75-year-old male with relapsed refractory diffuse large B-cell lymphoma. Initially presented with stage 4 disease and was treated with polar R-CHP ×6. He had a partial response after 2 cycles, but at his end of treatment scan had disease progression. And this is what his disease looked like. Now, he went on to receive second-line GemOx. He's 75, and in the UK, we can only access second-line CAR T for those patients who are considered eligible for autologous transplant. So this patient wasn't considered eligible for autologous transplant, so he went on to have GemOx. He had a partial response, but then progressive disease again. Now, he's got very extensive disease, this guy. You can see his PET scan shows a very high total tumour metabolic volume, and his LDH is 900. So this guy's got very proliferative, bulky disease. He's also got some comorbidities. He's got psoriatic arthritis, he's got an ejection fraction of 45%, and he's got renal impairment. And his current ECOG is 1 to 2. So I think this is that really challenging group of patients, and I'm sure we all see these. These are the patients who've got very primary refractory disease. So, what are we going to do? Now, CAR T-cell therapy, in theory, this guy's eligible. He's got third-line treatment, he's 75, but he's very borderline. He's got renal impairment, he's got cardiac impairment, and he's already got a performance status of 1 to 2. He's already received polar R-CHOP first line, so we don't really have any good bridging strategies for this guy. So whilst this guy's eligible for CAR-T, my worry would be he's going to progress in that time of manufacture and he's not going to make it to infusion. Bispecific antibodies, I think, are a good option for this guy. It's an off-the-shelf product. You can give it, and we've seen from the data I've just presented that about 40% of patients will get to a CR at third line, which is what he really needs. Polar I wouldn't use in someone who'd already had prior polar R-CHOP, so I personally wouldn't use 3. Loncastuximab would be an option for him. Clinical trial for loncastuximab had a CR rate of about 20% and excluded patients with significant disease bulk. So we elected for a bispecific antibody in this chap. He went on to receive epcoritamab. So tomorrow I'm going to do a session on managing epcoritamab and CRS in a bit more detail, so I won't talk about the management of CRS today. So this guy, I think, whilst he's eligible for CAR T-cell therapy, this is a sort of patient where I'd be really concerned that he's just not going to get there. And I think for this group of patients in the third line setting, bispecific antibodies actually offer a really, really good option. And we chose epcoritamab for this patient largely because of our clinical experience with epcoritamab and because the subcutaneous dosing makes it actually very easy to give. And as I said to you, CAR T-cell has its challenges, including time of manufacture, which would count against this guy. I'll skip through this just to go on to the second case, because I think I'm running very low on time. So this is a patient who's 62, who had stage 3 diffuse large B-cell lymphoma, which was treated initially with R-CHOP, achieved a CMR on the end of treatment scan, but then had a relapse that was confirmed on biopsy of the stomach. She did go on to receive second-line CAR T-cell therapy, which was bridged with polatuzumab BR, because she'd only had R-CHOP first time round. Got progressive disease after bridging therapy, but did go on to receive the CAR T-cell infusion. Had a CMR on a 1-month PET scan, but then had a progressive disease on the 3-month PET scan. So what third-line treatment option would you choose? And again, the patient's already had polatuzumab as part of bridging therapy, and I personally wouldn't choose that. Loncastuximab again would be an option. It's a licensed option for third-line treatment. But again, in the loncastuximab trial, there were actually very few post-CAR T-cell patients, and again, CR rates of only 20%. Salvage chemo plus autologous transplant, I guess in theory you could try that, but I think the evidence basis for doing an autologous transplant in someone who's received CAR T, I think it's going to be very difficult to harvest them, and giving them chemotherapy is likely to lead to significant morbidity. So I think, again, for this patient, I would personally have a bispecific antibody at the top of my list of things to give. And again, we chose to have give this patient epcoritamab on the basis that actually about just over a third of patients in the EPCOR NHL1 study had prior CAR T, and we know that the overall response and CR rate in those patients is similar to the overall population. And this patient did achieve a CMR. And again, just to remind you that in subset analysis, those patients who had prior CAR T-cell treatment had comparable CR rates compared to the general population of about 30%. So this is a good option for patients who've relapsed following prior CAR T-cell. And I just wanted to put this in at the end, really, which is just to remind you that actually, and this is very much mirrors my experience, that these patients actually are well. These are outpatients. They come to outpatient. They have an injection that takes a minute, and then they go home and they're completely well. And this is captured in the study looking at fat limb scores, which is looking at treatment-related and disease-related symptoms. You can see a rapid improvement in symptoms that's improved by cycle 3, day 1, and continues to improve. So, and that's really important, isn't it? Because we don't want to just make our patients get to remission. We want to make our patients get to remission and feel well. And in my experience, our patients who have this as an outpatient and remain on treatment are very, very well indeed. So, we've got time for some questions at the end, I think.
Yeah, so you're done?
Thank you very much.